This is just kind of showing you how to level, which we'll talk about a little bit more. One of the things I was kind of mentioning is I would like to get one of these levels, the laser level pointers, because I think it's easier to identify where you're supposed to be leveling at. And it's also much more accurate. I know, like where I was before, they had like this giant level, which they would set on the floor. Okay, yeah, not clean. It like gets set on the floor, and then we're like sticking it next. So if we can, yeah, exactly, and then you're trying to eyeball it. So if we can find a laser level, that would be awesome, and I'm going to try really hard to do that. And those are reusable, so you take them out each time, and so then you could store them here. So if we had an EVD, then we could just put it on for the next one. Okay, so the EVD is an external ventricular drain, so it's just a sterile system that helps us drain CSF temporarily while we can't have a shunt in place. So it comes from the ventricles in the brain, comes out through the skull and the scalp, and then into a external collecting system. And we do this to treat shunt infections. So a kiddo who has a shunt infection, we have to take out the entire shunt system. And we can do this for kids who may have a tumor that needs resected causing hydrocephalus. Maybe we're like, we're not sure that they'll actually need a permanent shunt. We can take out the tumor and see if we can wean the EVD to kind of save the kiddo from having to get a permanent shunt. Kiddos who have stroke and who have lots of bleeding and things, blood can clog up the ventricular system, so sometimes just putting this in place while the blood resolves is enough to save the kid from getting a permanent shunt. And then obviously as we're treating, if there is a shunt infection, then we can monitor the fluid as the kiddos get through their antibiotic therapies to make sure that the infection is resolving. So they put it in a catheter. Now ours will be covered, so I just wanted to show you kind of how it can look on the head though. It's going to be impregnated with an antibiotic catheter to help prevent hopefully secondary infection or infection if they didn't get this for reasons of infection. It goes into the ventricles in the brain, and then it will come out through the scalp like we talked about. If they have a valve, now sometimes, very rarely, they will have a valve on the tip of the proximal catheter, then those kiddos can be on the regular floor. However, if it's just a true external ventricular drain, they need to be in the PICU. And I think probably across the board for a while it would just be everyone's in the PICU. But they get the catheter secured to the scalp, and then you can kind of manipulate and make sure that the fluid is draining properly, prevent increased ICP, and then hopefully treat the infection and get them off and then replace the shunt. So two things, our goal is always to place this in the OR if possible, but there are times, like if a kid comes up to the floor and is in like severe distress, they have severe hydrocephalus, this can be done at the bedside. Again, not our preference, and hopefully they wouldn't get sent up to the floor from the ER with that serious of a issue. But it can be done at the bedside, and it's just a catheter that's put in there, secured to the scalp, and then connected to this very ancient looking system. So for the nursing role, the most important thing is to make sure that the drainage system is leveled properly and to make sure that your settings are correct, because if they're not correct, you can overdrain the kiddo, which can cause subdurals, it can cause a lot of problems. And if you don't drain enough, if it's not set correctly, the worst thing is herniation. Obviously we wouldn't want that. If you're not draining any of the fluid continues to build up. That's bad. So each time you get it, so this is an hourly thing in the ICU, every hour this has to be checked. So you'll come in, you'll make sure that you're leveled at the correct spot, which I'll talk about here in a little bit. You need to make sure that your Viratrol is at the correct setting on here, and there's two settings on here. There's centimeters of water and millimeters of mercury, you need to make sure that, and it will be all in your orders, but you need to make sure, because they don't exactly line up, that you have the correct one.
Do you typically, Natalie, all order from the same? Or do all Sheikh Patel and...
That is something I need to figure out,
Okay.
because I do not know what they prefer in the kids. And if we've not had any kids with it so far, I know there was a difference at St. Vincent, like the
Okay.
adults and the kids. So I will have to double check
Okay.
with them what they would prefer. Let's see. So anytime a kiddo is going to be repositioned when they have an EVD, they need to be clamped. So every time they get up, if they need to use the restroom, or if they reposition in the bed, they want their head up or down, you have to clamp it, reposition them, re-level it. And then when I say re-level, it's moving this system up and down so that this laser, which we're going to really try to get, is level with the ear, so the tragus of the ear, not this. So rarely, unless we change the settings, and that's usually done by the neurosurgery group, does the nurse need to do this. So one of the things that happened before is we talked about leveling it to the 0 level, and one of the nurses at the old hospital put it there and left the baby like that, draining all night, over drainage, subdurals. We don't want that. So you should never have a drain like this. So usually our setting starts at 10. That's usually where we start, and then as we get further out, we usually like to start gradually increasing it, so we'll go to 15 and see how the kiddos do. And then we look for output, we look for changes in the patient's vital signs, make sure they're not having any bradycardia or things like that as we raise it. And then we'll usually go to 20, and then we'll usually clamp it and leave it clamped for a day and see how they do. So we don't just like yank it out and say, let's see how they do.
So the lower you have it set, the more drainage that will come out.
Right,
Okay.
right.
Think of gravity.
Yeah.
Like
The lower it is, the more it
the
comes
more
out.
it comes.
Yeah.
Yes. So this is just talking again, clamping each time. So if you have a patient who's like super upset, crying, coughing, gagging, getting a respiratory treatment, clamp it to make sure that they're not over draining. I came in one time and I had a little patient and she had her EVD in and someone walked out of the room, which they're supposed to have a sitter usually if they're going to be left alone. She was crying, and I come in and she's just, pouring out CSF. We don't want that. So things like this can happen. That's why you have to be really careful with these. And then you clamp them, reposition them, or calm them, or whatever they need to do, and then what?
Can we sedate?
No. And then you just open the stopcock back up. Usually, so if your patient needs to go to the restroom or anything like that, you'll want to, so this is our patient, clamp it towards the patient so that they're not draining. And this is connected to the catheter that comes out of the head. And it has this little white piece on it that it screws into. And it should be a continuous system. This is a sterile continuous system, so we want it to stay that way.
So this actually gets hooked up in the OR.
Mm-hmm. Yep, they come back to the bedside. And this little thing is how it gets, I notice a lot of people don't like to secure it with this to the poles, but I prefer it because I don't like these swinging around. If these can't be laid in the bed too. If you lay it in the bed, it has some kind of mechanism that can mess up its ability to drain properly. So don't lay it in the bed when you're traveling or anything like that. These usually go on a separate pole by themselves, so not with the IV fluids or anything like that. Talked about all that. Again, if we're going to change the Virtrol level, that's usually done by neurosurgery. Okay, so this is, again, an hourly thing. So every hour you need to go in and do a couple of things. Make sure that there's fluctuation in the tubing. So even if you don't have output necessarily in your container right here, as long as you see fluctuation in the tubing, then that usually means the system is working properly. So if you go in and it's been an hour and you're like, okay, I don't see any fluctuation, look all over, I see no fluctuation, you can say, hey, cough for me or something, if they can, and see if you see anything then. If you don't, then you would call us. But if you come in, it's been 2 hours, we've had no output, and you look in there and you say, oh, well, I see it level, or, fluctuating, that's okay, it's working.
Where's it fluctuating at?
In the tubing,
The green tube?
so
Because that's coming out of your patient's catheter,
Yep.
so.
it will.
So, and there's pressure, and so with breathing, are you gonna see?
Yeah, that's what
sometimes-
the little up and down is with breathing and
Yeah.
stuff. But again, if you're like, I just can't see it, or it just looks like it's kind of stagnant, you can tell them cough or, try to do something, and then if it drips, then it's working. If it's not working, so you have no drainage, or you have no fluctuation and no drainage for 2 hours, you would call neurosurgery. This should be labeled when it comes to the floor, and these all should be in your orders. You should have specific guidelines too, so if you have too much output, so, if we say call for output greater than 40 in 2 hours, then you would call. And it would just depend on the patient's age and, let's see what else. Another thing is if you start to see all of a sudden have bloody drainage, where it's getting cloudy, anything like that, we would want to know about it. I think I kind of got sidetracked. We do want these labeled, so this should come back. And if it's not, I'd like to get a bright colored sticker to put on this.
I know, I'm like having a flashback, sorry.
I haven't seen them yet, but I would like one, and if there's not, then we can make our own or something, so that this is labeled as an EVD, so that everybody knows, which is clamped, that this is not to be injected into, it's not to be aspirated from. It's a EVD and it's a closed system, so we don't touch it. Now, if I need to come in, if this kid had infection, I can come in and I can draw off this, I can draw a CSF, but that's also a neurosurgery thing. That's nothing you guys ever have to do. Let's see.
So when you're talking about clamping it, with the position changes, is that there?
Yep,
Yep.
towards
Okay,
the
Just
patient.
wanted to make sure.
Yep, towards the patient, I clamp them, then we can go to the bathroom, get them all settled back, re-level before we open up the system again.
So it's a stop, huh?
Mhm.
Yeah.
Yep.
Yep.
All kiddos who have an EVD will also get normal saline replacements. If we're losing a lot of CSF, we can get hyponatremic, so we want to make sure that we are doing that, and that's done hourly. Again, so when you come in, you're going to measure each time, check your level. Okay, I've had 10 out, let it drain, return it back, and then you're going to put on your pump 10 mils of normal saline to go over, an hour until your next one.
Are you clamping the patient before you drain it?
Yes. Yes.
So for all your draining, are you always clamping at the patient, or do you clamp down at the chamber stopcock to drain?
Yeah.
You can clamp at the patient, clamp at my patient, oops, clamp at my patient, and then open this up, let it drain, turn it, and then turn it back on.
Okay.
I know, because we used to clamp
Right,
there
down,
also.
yeah, that's
Mhm.
Okay, all kiddos will be on a continuous heart monitor and pulse oximeter when they have a EVD in place. They can, in certain circumstances, ambulate, but they have to be clamped, and it's only in certain patients who are stable when they're walking and who have, the neurologic capability to know not to pull or drain. If they're unsteady or anything like that, we will have them be walking, but that will be done with like a therapist or something like that.
Use the IV for a patient like this.
We would like it to be done on like short, brief periods of time. We don't want to keep them clamped for a prolonged period of time. If the patient has to go down for a test, they need to be clamped. And again, we don't want this being laid in the bed when you travel. The nurse must be with them, has to be clamped, and they have to take their monitors with them. There should be an emergency kit kind of made up for any kiddo who has an EVD, which is just basically like hemostats and sterile gauze and alcohol. And alcohol, in case the tubing were to get disconnected.
So tell us what you do then with,
That's on another slide, so,
okay.
that's okay. So, we'll go over that one, the next one, when we get to the complications one. Again, some kiddos, if they have a shunt infection, will have intrathecal antibiotics ordered that we can instill into this. Again, that's neurosurgery, so you guys never have to do anything like that, but basically come in, we inject into the system, their system, not the system, and leave it in, clamp them for an hour, and then it would be the nurse's job to come in an hour later, unclamp it, and let the medication drain out.
With that increased amount of pressure, do they complain of headaches or anything like that? So would you pre-medicate them before those periods of time?
Not usually. It's a small amount. I've never had, we've only had to do that one time for a little kiddo. It was a baby who had it. And usually the goal is to treat with IV antibiotics, not to put anything in the system or into their head. So that's our
For the IT antibiotics, do you, pharmacy knows that they would need like the preservative-free
intrathecal. Yeah, it has to be.
You would order it that way?
Yes, it has to be special. It's not just like the bank that you would
Right.
put in, just, to the IV. So it
would
does have to
be
come.
special.
And it would be something that you would request up, like if we say, hey, we're gonna come, we need to do this, we would have you request the antibiotics, cause there's only a small time frame that you can instill them after they come up, so.
So if they had, would they ever go to MRI with this?
They can.
So where would we, I'm trying to think of where we would hang it.
They should have methods of places they can put it.
Okay. Cause like our lines and stuff, we lay in the bed with them. for
Right.
MRI, so I just am trying to think of. and
No,
that's all
we would just
compatible.
have to you can't, they can go down there with that, we just have to figure out, the
No
best.
free pole to put it on.
Yeah.
Me-
Isn't there,
me
because
no
usually the
serve,
IV gets wet.
Yeah, that's what I was saying.
Yeah.
It's usually at the top, and if you lay it, then there's like a filter, and then it supposedly doesn't
And then
drip.
it won't drip, the filter gets wet.
So you wouldn't be able to put extension tubing
No,
on.
no.
You don't ever
You can't
break it.
break that, yeah.
No.
So I'm trying to think of what we would do with that.
We'll have to cross that bridge when we get there.
Yeah.
But I know it's possible. I just don't know how they do it, because they do it with adults, so.
Okay.
So this is kind of the complications we were talking about. Electrolyte imbalances, if we're not replacing them, they can get hyponatremic, so we wanna make sure that, we avoid that at all costs. With the normal state of replacements, we should hopefully avoid that. Obviously, you're gonna watch for signs of increased ICP. Same kinds of things with like a shunt malfunction, those are the same kind of symptoms you would look for here. Bulging fontanelle, really irritable, really sleepy, vital sign changes, so bradycardia, high blood pressure, neurologic changes, pupil changes, all those kinds of things. Infection is a huge risk after these are put in. Now, we do not typically keep a kid on IV antibiotics through the whole, when they have this in. So if they have a shunt infection, of course, they're gonna be on antibiotics, but we're not gonna keep kids on long-term antibiotics just because they have these in, because these can sometimes be weeks at a time. So making sure we are watching the incision or the insertion site is really important. The dressing should be occlusive. If you start to notice that it looks like it's coming up or anything like that, then we should know about it. We'd rather not have anyone else changing it, because you can pull it out inadvertently if you pull off that tape and it's stuck to the
Do you
tubing.
want us to reinforce until you're able to hit the floor though?
Yeah.
Yeah.
That's what I'm thinking, like 2:00 in the morning and
Yeah.
they're going to do their assessment and it's peeling up, you
Yeah.
just want them to reinforce
And then
and
we
then.
can change it.
Do you
And
usually,
then, nope, go ahead.
do you usually have an issue with that, considering the hair on their head?
I've had like one kid who kept leaking from the site. That was an issue, because then the dressing would become unocclusive. That's one of the things you monitor for, but it can be. It doesn't always stick to the hair really well, so. We talked about the change in the CSF consistency, so if you see blood start to come out when there was no blood before, bright red blood, or you see cloudiness, anything like that, then we can always come and look at it, and then if we say, we're concerned about, infection, then we can draw fluid and send it. Obviously, seizures are something that any kid with a neurosurgical intervention can have, so you would just do what you would usually do for a seizure.
Does Dr. Fulkerson place these, like in the adult world, they place them, I think, more frequently for ICP management?
He doesn't for kids, really.
Okay, I haven't seen.
No, it's
anything
mostly
like that
for
yet.
drainage,
Okay.
you can always do both, but rarely do we ever do that. There's a way that you can get a crude estimate of their ICP by just this system without the transducer and all that kind of stuff, but typically we just use this itself. Okay, so this is if something accidentally comes apart or gets removed. So if you accidentally remove it or this comes apart, what you want to do is get a sterile gauze and you want to clamp it. If you can, don't reconnect it, that's the biggest thing. If you feel like the catheter may have gotten pulled, so you'll be looking at the incision frequently, or the insertion site, and if you look and you say, hey, I thought it was, at this point and now it looks like there's more out, let us know, and if we're not draining or things like that, then we'll probably want to get imaging to make sure it's still in the right place. Usually though, if you think it got pulled but it's still draining, it's usually okay.
Are there measurements there, that, like the pit lines
There's
and stuff like
dots.
that? Dots?
There's little dots on there.
Does he tunnel his catheter under the skin, or does it just go in at the insertion point?
Usually goes in at the insertion point.
So
And
it's
then he
just straight
sutures
in.
it?
So
Mhm.
not, okay.
I prefer, and I think now he doesn't really, he always sutures. We had one that they stapled in one time, and the staple was fine, but it came up in one spot that no one could see, and it punctured the catheter, and then it kept leaking. So that's pretty much it. So just lay the patient flat, call us, clamp them, and then usually we'll just get a new system and reconnect the
So
system.
if it just comes disconnected from the EVD, the drainage system, just clamp it, put a sterile
the-
gauze on the?
Yes,
catheter.
so so if it comes apart here, obviously don't clamp this, we don't care about
Right,
this. But you would just put a sterile gauze on there and then clamp it,
okay.
so then it's kind of covered and
Do
hopefully.
you try to alcohol it at all, or no? Okay, because you said alcohol, I didn't know what the alcohol was.
Well, that would be for later if we try to
okay.
reconnect it.
Okay.
Because I've only ever had to do that one time. What we did was we had to clean it really well, get a new system, cut it off where it had come in contact with the bed, and then reconnect it. But with a whole new system.
And that all comes in the kit that is in the OR.
No, that is a kit we'll need to
I'll
have.
make it up, we'll
Okay.
make it up.
But the kit of the new EVD setup, so we don't have any EVD supplies on the floor
Right.
currently.
I think
so-
what we talked about with surgery with Jenny was that we would just call for the kit when we needed it.
Okay.
Or that
But
because
that's
they
what
would
I'm
bring it
asking,
up
like, we
with
would
all
get
the,
it.
yeah,
Right.
yeah.
Right.
From the OR. if
And that
we
was
don't
Dr.
get that.
Fulkerson's decision that we
Right.
didn't need it up on the
Yeah,
floor.
Right,
that's
yeah.
fine, just making sure though that that's where we get it from.
Yep.
so.
Because we had talked about building a neurosurge cart
Right.
up here, but he said that was
Yeah.
necessary that we.
Incision care, again, same kind of stuff. You're gonna have a sterile dressing. They're usually gonna be sutured in. The catheter is usually sutured in. If it needs changed, then we would change it. We want you just monitoring the incision, making sure that there's nothing that looks abnormal or like infection, because these can get secondarily infected. So you can get a kid with a shunt infection who's even getting antibiotics, who ends up with a different kind of bacteria, which we don't want. Kids who have, especially young kids with shunt infections, have poor outcomes in regards to like their development and their learning and stuff if they get a shunt infection, so we want to try to avoid that. Obviously, if they have an EVD in place, they cannot shower, and then usually once they have the EVD removed, we would let them shower in about 2 days. I think Dr. Fulkerson's good about doing like a stay stitch, they call it, which is like a stitch around the catheter so that when we take out the catheter, we don't have to put a new stitch in. It's there and we just tighten it.
Oh, nice.
And I had talked to, I know one of the child life specialists had talked to me about the drains and stitching it afterwards, and so I talked to them about that, and hopefully we can try to get everybody to do that so that we can avoid having to take a suture to the head after we take out the drain. Because the drain itself coming out doesn't hurt, it might be, it's just like a little pulling, but it's the pulling off the tape and then digging around sometimes, and then the after part trying to put a suture in there when they're.
So you'll put a clear tegaderm over the top,
Mhm.
so. we'll
And
just
they,
reinforce
so
with that.
the stay stitch, just so you know, because I remember like looking at this as a nurse and being like, oh, I think I need to cut that, is like these clear things, and it's taped around the catheter, so don't cut that. I'm like, oh, they left a stitch or something. No, it's supposed to be there.
How do you guys, change your dressings only when they become unocclusive?
Yeah.
Okay.
And then any questions or any concerns, just call and we can come look at it. But again, I think the most important take home is to make sure that it's leveled properly. And I don't know how I skipped over this, but this is also really important. I missed a whole slide, I think. Parents are not to touch the EVD system. This is only a nursing, so you can't do PCAs, can't touch it either. So if you have someone in the room, like a sitter, and the kid wants to get up, they can't clamp it, they have to call the nurse, and the nurse has to come in and they have to do it, and they have to re-level afterwards, and unclamp them and all that kind of stuff. So just kind of explaining that to parents and letting them know how important it is that they don't touch it. And then the other thing is sitters.
Teaching the parents how to do it.
Yeah, definitely, yeah.
Oh, I remember that.
I remember that too.
Sitters, if we think the kiddo needs a sitter, if like the family's not gonna be at the bedside, that's something that we may need to do, especially, if the nurse can't be in there all the time. That's something we'll have to kind of discuss. I don't know if you guys have just sitters, or
We
they're
actually
hospital
done our
sitters.
unit assistants sit, and then depending on, we have a big behavioral health population, so we have 3 behavioral health patients in the ICU right now, so sitters are allocated to them as well.
Okay,
So,
Yeah, but if you're in charge, you know that you rarely get a sitter.
right, from the house, so it's usually our
So-
own unit assistants that we're pulling on for their other jobs
okay.
to sit in that.
If a patient were to pull their tubing out completely, which has happened many times, just put a sterile gauze over it and a tegaderm and call. It happens. All these things happen, so we wanna try our best to avoid all of that, definitely, but, at Riley, at St. Vincent, all these things have happened before, so.
So are these patients not necessarily one-to-ones? Like,
No, not,
sounds like they're pretty stable
sometimes.
for the most part.
It
So,
depends.
this can be a trauma kiddo too, who may not be stable in that sense. It can be a shunt infection, and those kiddos are really sick. Tumor kiddos, the hydrocephalus, can be very fragile, and, bad things can happen quickly. So, these aren't necessarily stable patients. Hopefully we get them there, and, then it's kind of maintenance, and you just manage it and kind of gradually wean them, but it's not always the case.
But they can be like fully awake,
Mhm.
tossing, turning in bed also.
Yep.
They're not necessarily like
In a wheelchair.
They're not-
Really
sedated.
bad.
Yeah.
Hopefully. Yeah.
Well, that's what we call the posy beds.
Oh.
Nope.
That's what we used to nickname them.
Really?
You are old.
Any other questions about anything?
When in doubt, call.
Yep.
Just be hyper alert with these patients because gravity is very important and the position changes
And my big thing is just making sure that you have it right, and if you don't, just know that it should never be
0.
down here.
Right.
When we say, level it and stuff, we don't mean arbitral, we mean at the patient's.
So you're
remove the
adjusting the whole
whole
thing,
system.
the whole system up and down.
Yes,
Yes.
not, this will usually say,
Right.
this is what you're
Like
moving.
Mm-hmm.
Kind of, yeah.
Cause that acts as like your transducer kind of.
Yeah, if we were,
measurement
and we
there.
could, and we can add it in a transducer if we needed to, but again, he doesn't usually use it for that. And you can actually lift this.
Extra bags of those on the
Oh, yeah, the
floor.
drainage
Oh.
bags.
We have to
So. we
When they
would
get
clamp-
3/4 full, I will come change it.
Oh, you
Oh,
will,
you guys
just
do
call,
Yep.
okay, all
Yep,
right.
we can change it.
Okay, cause then we used to change them,
Oh, okay.
scrub and change them,
Just less
but.
hands in the pot.
yeah,
Oh,
so
I didn't,
we're
well,
More than happy to let you, unless it's in the middle of the night, then what are you gonna do?
well, the thing is, we should start be thinking about that once it gets like 3/4 full. So I would hope that between, once we start thinking, oh, it might be getting full, that we're not gonna come back in the next day and then have the entire bag full, because did they over drain or something, so there should be
Yeah.
some kind of,
What's your
Wait, so
typical amount of drainage out?
you're emptying this part you can just leave in.
Well, you make 30 an hour-ish.
Yeah,
So.
Depends on the
depend
kid.
on-
So, like in babies who have ventriculitis, so they have a shunt infection, their CSF usually slows down their CSF production, and as the infection, we always used to get calls about this, because as the infection would start to clear, they would start putting out more, and then the nurses would get nervous, like, oh, they're putting out a lot more than they were, 2 days ago when I had them, and that's okay, that's usually, so a lot of times with those shunt infections, they don't put enough, or they don't put a lot out at first, and then things start to pick up as they get better. So it's different, but each kiddo should have orders, and if you don't see orders with like, oh, call for this much out over this much time, then let us know, we'll make sure those are in. Cause there's like a order set, I believe, with specific information.
So what is so like the little patient that we just had, that had the large shift and a lot of hydrocephalus, or what made them do burr holes versus placing an EVD?
That's a good question.
We didn't have the talk yet.
Well, no, I think there's a couple,